Hello.
Hello, good evening, sir.
Yeah, Raki. All good.
All good.
So I think we are early. In the interest of time, we can start sharing the slides. And then I don't know who the chairpersons are. Dr. S.P. Mishra is there, no?
Sir, I
Oh,
was thinking
Hitendra
that,
is also. Yeah, Hitendra is also one of the chairpersons.
Good
sir,
evening, sir.
Yeah, Hitendra.
Yeah.
Hitendra, are you okay? And if in the interest of time, we share the slides right away before we start the session, so that because immediately after this, I have to rush to Hall B.
sir, this is all, should I share these slides? That's what I was thinking. Because,
I think it's better to just speak it out.
hmm,
I will ask you the question and you speak it out. That might be better.
yes, sir.
They, oh, see, yeah. So Ankur is there, and Ankur is already there. Hitendra is already there. S.P. Mishra sir has to come.
I think
Hello,
sir.
sir. Hitendra, sir. Hi.
Hi, मैं राकी पहले बोला.
अरे सॉरी मैंने सुना नहीं. कैसे हो आप?
मैं बेटा बढ़िया. तू कैसी है? How are you?
It's,
आज फायदा हो गया हम लोगों का सेकेंड डे सेशन होने का. I watched the entire javelin thing. That was amazing.
I
With
think
sir?
the,
I mean this time we won highest medal.
no, but
गोल्ड मिल गया इस बार
this
तो.
fellow is amazing, and the second throw, which he threw at 87.58. The moment he jumped in the air, he leaped with joy. He knew that he'd crossed his earlier best, I think, which was also not crossed by the runner-up.
I think sir he was in top in qualifying round also. He was
86 something था उसमें, but this time he crossed 87.
We are live.
और लाइव कैसे हो गया यार? अभी तो 24 बज गए. Are the slides visible?
Yeah, sir.
Sure. He's just cramped the whole program. This one finishes at 8:15 and 8:25. The other one starts in Hall B.
Yeah, I was judging the posters. अभी बस वो थोड़ा लेट चल रहा था. मैंने कहा अभी थोड़ा और लेट हुआ तो it will be ऐसे ही चलेगा.
I think we could have done it over 2 weeks, then everybody could have attended every session. Yesterday also, I am told the NAFIL symposium was very good, but
we missed the NAFLD symposium. And HCC भी था yesterday, parallel postgraduate.
HCC में नीरज का अच्छा टॉपिक मिला था उसको.
Sir, your voice is I mean not clear to me. I mean Raki maybe
not able to hear.
Now better.
Okay. I'll probably hold this.
Hi, Dr. Sunil. आपका नाम समायरा लिख के आ रहा है.
Let me try. Hitendra, is this any better?
But
is this better?
Yeah, it's better, sir.
Right. Maybe this is closer to the mouth, the right one.
Sir, आप कौन सी definition में believe करते हो? धर्मेश sir.
No definition.
हाँ, नहीं अपने day to day practice में. I'm honestly I'm asking. Which one do you feel is better? Huh?
What's in a name? A rose is a rose. ये जो definitions होते हैं ना, ये paper लिखने के काम आते हैं. There, otherwise.
Hey, real life. That's what I'm saying. Real life में, which definition do you feel is?
So, see, there are problems with everything. For example, the apostle one doesn't let you have any such event in the past, which is obviously not true.
Hey, Raki.
There's so many.
There are 30. There are 30 definitions, and we are ready with the 31st.
सर आगे मालूम पड़ गया
पूछ
आप
रही
सबको।
होगी what matters in the definition when we see a
Sir,
patient, we
good
try
evening.
to put that's not right. Each patient.
The problem is we always see things from our point of view. We don't see from the
No.
patient point of view.
No, students ask us ना sir, हम लोग बड़े उसमें पड़ जाते हैं कि क्या है ये ACLF है, ये क्या है?
कुछ नहीं है, थोड़ी देर में खत्म हो जाएगा।
उसका एक ही आंसर है, सब मिथ्या है।
In your practice, does it make any difference?
No, like I'll tell you, we have a patient जिसको अभी मतलब last 2 months से jaundice था, then encephalopathy and ascites. Okay, so drug induced है, मतलब super added Giloy and all that. So he doesn't fit, but that patient has come with cerebral edema, ascites mild, moderate है, ACLF है नहीं, prior.
Why is it not subacute liver failure?
Subacute है, so
Yeah,
subacute
that's a
liver
subacute
failure.
liver failure. This one
No.
is not a difficult one. There are
But it is
other
very mild,
situations.
but cerebral edema and all that. मतलब subacute ही है, but people have abandoned that term ना. So after the
No,
ACLF.
it is not. We
नहीं
just have
नहीं,
not
इसीलिए तो
abandoned that.
वही
It's not
वही
abandoned
पढ़ाते हैं
that.
हम लोग कि सब acute है ये, या ड्रग या सिवियरली रख लो उसकी
राखी इट इज अप वन अपमैनशिप वाली बात है इसमें।
है जी सर।
वन अपमैनशिप है, मेरा डेफिनेशन होगा तो मेरा डेफिनेशन होगा।
हाँ।
गुड इवनिंग।
वो डिपेंड करता है कि पेपर छापना है या पेशेंट को देखना है, उसके ऊपर
बिल्कुल,
डिपेंड
बिल्कुल,
करता है।
सर डिफरेंट है पेशेंट्स, अगर लेबोरेटरी में देखें उनको तो दे आर डिफरेंट।
What was the transjugular liver biopsy in that patient?
No, ultimately that patient needs a transplant, and
Transjugular liver biopsy was suggestive of पूरा drug induced bile duct complete loss and cholestasis.
I mean,
ऑफेंडिंग ड्रग वाज,
हाँ जी सर,
ऑफेंडिंग ड्रग क्या था?
इन्होंने वो खाया था गिलोय एंड दैट आयुर्वेदिक।
अभी मैंने देखा, अभी बस देख के आ रहा हूँ अंदर।
भाई
SGPT 3000।
यस सर, एंड SGPT चल रहा है 600, उसमें कोलिस्टेसिस है, अल्कलाइन
लेकिन
फॉस्फेटेस बढ़ा
एक और देखा मैंने, कोविड में बहुत इरेटिक SGPT आता है। गुड इवनिंग।
डॉक्टर दीपक।
गुड इवनिंग सर। सर मैं पहले बोला
सॉरी यार,
गुड इवनिंग सर, 7:30 स्टार्ट कर दूंगा सर शार्प।
हाँ बेटर
बस इसीलिए पहले से आ गए हम लोग ना। तनेजा साहब को पता है, वैसे भी PGI वाले जो होते हैं थोड़े से टाइम के बहुत स्ट्रिक्ट होते हैं।
डॉक्टर कौशल ने बोला है 7:30 स्टार्ट करवा देना बस सर।
7:30
बिल्कुल सही।
15
So I think we are going to be live in 15 seconds or so.
एक मिनट बस, ठीक, ओके।
Hi Sunil.
Hello sir, hello sir.
Sir, do we have all the panelists there?
Sir, I have joined.
Deepak
Hi,
Koval
Ashita.
sir is there. Hello sir, good evening. Hi
Hi,
Shweta.
Rakhi.
Hi, how are you?
I'm
Hi
good.
Charles.
hi, good evening, hi.
Okay, so
Anyone from the technical team?
कुछ नहीं है अभी।
We are all
SP
coming
मिश्रा
vertical.
सर देखेंगे। SP
हम लोग सब
मिश्रा सर
वर्टिकल हो
देखेंगे
रहे हैं,
सब कुछ।
हॉरिजॉन्टल
हॉल A चल रहा होगा एक्चुअली, इसलिए।
Orations तो चल रही हैं, but Dr. Kaushal said that you can start the case-based discussion here.
We are in a different hall C हम लोग हैं।
All these,
Yeah.
all
We
these.
can
Hi
start।
Nipun. Hi.
15 सेकंड हो गए भाई। सुनील,
सर एक मिनट, वो टेक्निकल टीम वाला ही नहीं है कोई भी।
अच्छा
अरे सर है ना, क्या टेक्निकल टीम पूछ रहे हो यार तुम?
सर we have to be live सर।
अरे यार,
I have passed the baton to the younger generation। राखी आ गए।
ओ वेरी गुड। कल कार सर पूरे फॉर्म में थे सर।
अच्छा,
ओ बाप रे।
उनका वो देखा नहीं तुमने? एक ताला लेके चलते हैं, बोले मैं कार से डेविड कार लॉक हो गया हूँ।
एक डेविड को पीछे बिठा लेंगे तो डेविड कार लॉक हो जाएगा।
डेविड कार लॉक हो जाएंगे। यानी कार साहब वैसे भी फॉर्म में रहते हैं, एकदम लेक्चर देते हैं जैसे कि इलेक्शन।
नो आई एम टॉकिंग ऑफ द बैकग्राउंड नॉइज सर।
अच्छा, ये टॉकिंग ऑफ
Oh,
बैकग्राउंड।
it was true. मैं तो 2 मिनट के लिए
Hello,
सोच
sir.
रही हूँ, क्या हो गया?
Sir,
यस यस,
good evening sir.
गुड इवनिंग। हाय
Sir, you can start.
यस
Start now? Okay. So, good evening everyone, and we welcome you all to the second day of the Inasl conference, and we've had a very interesting day yesterday and hope to continue with the same today. So we have two very interesting panel based discussions, and the first one will be initiated by Dr. Dharmesh Kapoor, and this is on management of a critically sick cirrhotic patient. For this, I invite the chairpersons, and I invite Professor Professor Mishra and Dr. Ankur Jindal and
Hitendra. Dr. Hitendra, okay.
Dr. Hitendra. Yeah. So please start the proceedings for this.
Good evening. So we are starting a new session, managing critical ill hepatology patient, which is a non-ACLF patient. And it's a panel discussion. And it's been moderated by Dr. Dharmesh, who's a senior consultant at Yashoda Hospital, Secunderabad. And our panelists are Dr. Raki, who's the additional professor in hepatology at ILBS, Dr. Deepak Gobel, who's the senior anesthetist and critical care specialist at Medanta Medicity in Gurgaon, Dr. Shweta Singh, anesthetist, senior anesthetist and intensivist at Max Hospital, Max Saket Hospital in Delhi, and Dr. Charles, who is the hepatologist at Aster Medicity Hospital in Kerala. So I request Dr. Dharmesh to start the case panel discussion. Dr. Dharmesh, hello.
Dr. Dharmesh, you are muted.
Hello.
So with the permission of the chairperson, we'll get started. So this case study is a story of a 57-year-old male who's obese and whose corrected BMI is 32. He has background alcohol use disorder, but he's been abstinent for the last 7 months. He was referred from the state of Maharashtra to our Center for Liver Transplant. The primary indication for referring to us was a right hepatic hydrothorax, which was refractory to diuretic therapy, and he had undergone thoracentesis 3 times in the preceding 4 weeks prior to presenting to us. In the last 2 months, he had been hospitalized at his native place for melena and for acute kidney injury, which was precipitated in the first instance by an episode of spontaneous bacterial peritonitis, and subsequently on 2 further occasions because of diuretic therapy. And in these 2 episodes of acute kidney injury, his creatinine had gone up from the baseline of 1.1 and 1 respectively to values of 2.1 and 2.2. He had not undergone any interventions by way of endoscopy, and he had never been transfused prior to coming to our center. Oh, not able to move the slides.
So even for melena, he was not, no endoscopy was done?
Yeah, so an endoscopy was done, sir, but no intervention was done. So they said that it was because of portohypertensial gastropathy. They didn't see any varices which were worth subjecting to endotherapy. On examination, he was conscious, oriented. He had tachycardia. The blood pressure was 120 by 65 millimeter mercury. Respiratory rate was 28. He was using the accessory muscles of respiration, and he was saturating 85% at room air. He had lower limb edema till mid leg. The JVP was 3 centimeters elevated. He had pallor, icterus. The palms were pale. He had no clubbing or cyanosis. He had absent breath sounds on the right side, anteriorly and posteriorly, and left side, the air entry was good and there were no adventitial sounds. On per abdominal examination, he had grade 2 ascites and the spleen was palpable 3 centimeters below the left costal margin. So, Dr. Charles, since we've been asked to dwell on the subject of a critically ill cirrhotic, and I really don't know what that is. So, what would you say? Is this chap a sick cirrhotic? And if so, is he critically ill? And what is your definition or what are your thoughts on this subject?
Yeah, when you talk about critical ill cirrhotic, it's a cirrhotic who develops a life-threatening complication that can increase his risk of morbidity and mortality. And about 70% of the time, they do not meet the criteria for a ACLF as per APASL or the ESL criteria. And some of these complications, it may be first GI bleed, it may be a hepatic encephalopathy grade 3 or 4, it may be a hepatopulmonary syndrome, severe hepatopulmonary syndrome or portopulmonary hypertension, it may be a refractory hydrothorax that is compromising is causing increased morbidity and mortality. And some of these patients develop severe sepsis or acute kidney injury or spontaneous bacterial peritonitis. So most of the time, patients admitted, about 70% of the patients admitted to or ICU, they do not meet the criteria for ACLF. Only 30% of the time they meet the criteria for ACLF. And this patient is a sick cirrhotic. Whether he's a critically ill cirrhotic, I don't think so, because he's not admitted to ICU, and he doesn't require an organ support, or doesn't increase his short-term mortality.
Right. Do you think there is an objective definition which defines this, or any MELD score or any other score that you are aware of which might define such a patient?
In our practice, we use the Cliff acute decompensation
Mhm.
score to define it, and
Right.
MEL also helps us to define a critically ill cirrhotic. So any patient with cirrhotic, now in our practice, any cirrhotic with a MEL score more than 25, then the patient is very sick.
Right. And can a patient not having ACLF be critically ill? I think you've already described that. And any patient who might be having even something like a refractory GI bleed or encephalopathy, or someone who's got other complications which are not so common, as you mentioned, hepatopulmonary syndrome, they can be critically ill. And important to state at this stage that you need not have access to lab data. So if we use the criteria that you must just mentioned, like the Cliff ACD score, then you AD score, then you need some lab data to be plugged in before you can say that this patient's score is beyond this. So I think this gentleman who's been in the hospital at least on 3 different occasions for different reasons in the last 2 months is saturating 85% at room air, is using accessory muscles of respiration, and is tachypneic and tachycardic, has SIRS criteria, at least 2 of them on clinical examination. For me, I think he would be a sick cirrhotic. And I think the importance of having this panel discussion is how to prevent a cirrhotic who needs care or some intervention to become so sick that he would become critically ill. Because we all know, and this is something that is known from across the globe, that when cirrhotic patients come to the ICU, they have an extraordinarily high mortality, and there will be generally more non-survivors than survivors. So this is something which has been borne out in studies done among cirrhotic patients in the ICU. So I think it's really a matter of semantics, but I would in my practice say that someone who needs intervention, someone who needs constant monitoring, and in whom you can prevent him from going over the brink, is probably a guy who's a sick cirrhotic, and do not let him become a critically ill cirrhotic. In more recent times, this particular study again by the Cliff Consortium has come up, which tells you that you can probably describe a decompensated cirrhotics into 3 categories. So this was an elegant study. Why I say elegant is because it was done over a very, very short period of time. So 48 centers in Europe, in just about a year, they enrolled 1,000+ patients. And herein we can see that decompensated patients with cirrhosis can be divided into 3 categories: those who are likely to, or those who go on to develop ACLF in the next 3 months, and then unstable decompensated cirrhotics who get at least one admission. This fellow has been admitted a number of times, so even though he might not fulfill the ACLF criteria, we will see what the labs throw at us. And the stable decompensated cirrhotic who does not get hospitalized when followed up for a period of 1 year. And mind you, the right-sided curve tells you about the mortality beyond 90 days. So conventionally, traditionally, we speak about the mortality in the first 28 days and first 90 days in the context of ACLF. But these 3 categories, you talk about mortality beyond the 3 months up until the first 1 year. So the pre-ACLF are the ones who go on to develop ACLF, and their mortality remains pretty much what has been described in the canonic study, which is 53% and 67%. But the unstable cirrhotic patients have got a mortality of 21% at 90 days and 35% at 1 year, and which is quite high. And so this patient at least would fit into the second category. The stable decompensated cirrhotics, no deaths were reported in this cohort in the first 90 days, but about 10% of them died between the 90 days and 365 days. So I think this you could use as an objective parameter. When I plugged in the score of this patient, it came to about 67. And as you will see, his MELD is 26, MELD sodium is 26. So basically MELD is only to allocate or to prioritize you on the wait list. But in our day-to-day practice, we also talk about who are the typical high melders, and we think that these are the patients who should be watched very closely. And at least in the Western hemisphere, the MELD more than 25 need to be validated on a weekly basis. So that means at least these patients would return with their lab data, if at all not clinically, at least in a week's time. And that just adds to the acuity of the clinical presentation. So what we decided is, well, like happens in private practice, so this patient has been referred for transplant. So let's have at least some basic data on him. As would happen for any cirrhotic who comes to our hospital, he would be sampled. So both the ascitic fluid and the pleural fluid was sampled, and it was suggestive only of a hepatic hydrothorax. There was no evidence of any infection. And you can see some other key parameters. The INR was 2.7, the creatinine was 1.1, and the total bilirubin was 5.2. So predominantly the INR was driven by the MELD score was driven by the INR and the bilirubin. And again, that is very important. And of course, for constraints of time, we cannot describe as to why these things are important, as to what is the driver of MELD. So on examination, on his ultrasound examination, we found that the portal flows were low, about 8 centimeters, but still hepatopedal. And he had moderate ascites, he had gross right pleural effusion with underlying lung collapse, and nothing else of note. So there was no thrombus in the portal vein or the superior mesenteric vein, and there was no SOL detected on liver imaging. So this is what his chest X-ray looked like. You can see that the right hemithorax is opaque, and that the trachea has been and the heart has been shifted to the left. So he had a significant pleural effusion on the right side. This is what his echo said, and we will come back and ask Dr. Govil and Dr. Shweta on their comments on this. So, Dr. Rakhi, if I were to ask you, how would you assess this particular patient? You know, this gentleman, and why I'm asking this question is that he's come to us primarily for ascites and hydrothorax, and there have been two occasions in the past when he has been subjected to diuretic therapy, albeit modest doses of spironolactone and torsemide were used, and he developed acute kidney injury. So what is your take on assessing the renal function of a patient like this who would come to your clinic?
Yeah, thank you, sir, for showing such a nice case. And what I gather from here is that even though we've not heard about this entity like a refractory hepatic hydrothorax, so we know that in natural history of liver disease, after refractory ascites, you get hydrothoracis.
Yeah, you could
This
say it's a
patient had,
refractory ascites only, because at the end of the day, it is the ascites which gets sucked up into the
yeah,
pleural
so it's
space. Yeah.
now this patient is requiring repeated thoracentesis, and he has a pulmonary issue, and the ascites has now subsided. That's what I understand. The second thing which I get from this, so he is very advanced in the liver disease with 2 prior episodes of AKI, history of diuretic intractable, means it is not responsive, and he's getting AKI after diuretics, so he's not tolerating the diuretics. So, sir, you said about modest diuretic dose. So he's on diuretic. The
No,
creatinine
he
is
was
1.
not. Yeah, he was not on
So he's
diuretics
not
when he came to
tolerating
you.
diuretics, and he has some mild baseline renal dysfunction, which I can see from his serum creatinine. Expecting the severity and advanced nature of the liver disease, I would expect sarcopenia in this patient. So the creatinine is definitely not telling us about the exact renal functions. But for us to assess his renal function, the creatinine, which is elevated here, is definitely looking as a part of chronic renal dysfunctions. So I would like to have a assessment of his baseline creatinine in the last 3 months. So you showed us 2 values of 2.2, 2.3. So he has been having insults to the kidney, which has been repeated. So here, in this particular patient, first thing is to be very cautious, because like we get paracentesis-induced circulatory dysfunction, he's definitely predisposed to get AKI with even thoracentesis if we do large volume pleural tap without replacement. So there is where we have to assess. Now, how do we assess the reserve of this patient? How much is the renal dysfunction which has happened? And how do we know whether it is HRS, AKD or not? So for that purpose, I would like to see some serial creatinines and see whether it has been stable, and this is the lowest value. I can do a serum cystatin C level in such patients. If this patient I'm seeing as an outpatient and I see a cystatin C level, most of the times these patients will have a cystatin C above 1.8, 1.9, or above 2 sometimes. So
His
that shows
cystatin
us,
C was 1.25 milligrams per liter, and his values of creatinine, like I said, were 1 and 1.1. And every
yes,
time he received diuretics, there was a blip, and they went up to a peak of 2.2.
Okay, so 1.25 maybe the whatever lab and whatever the units we are checking the cystatin. So this was a normal cystatin C for this patient. He had a normal cystatin C.
So yeah, his cystatin C at the time of presentation to us was 1.25 milligrams per liter. So you could say anything more than 1. Some people would call it abnormal because it's a very wide range. 0.8 to 3 is the normal range. Some people would even
Then
consider.
it is a normal cystatin C. What I would expect in such a patient would be around 1.9, 1.8. In such patient, that is our experience. 1.3 and above, we have shown that in patients with advanced liver disease, if the cystatin C is above 1.3, it is a marker of development of AKI, new AKI episodes. Now, this patient has already developed episodes of AKI. He has diuretic intolerance. So I'm suspecting here some form of renal involvement which has set in here.
Would you
And I
want
would
to challenge
expect
him
the
with
highest
diuretics again? Would you like to challenge him with diuretics
No,
again?
sir. I would admit this patient, and in our center, like we would admit him in HDU setting. We will give him an IV. We will tap the pleural fluid, and we would like to give him albumin replacement and see. And because the tachycardia is there, he's using his accessory muscles. So this patient definitely needs admission and care.
Dr. Charles, would you want to give him a trial of diuretics?
No, sir.
Right. And see, this is something that some centers might be set up to do, like getting the cystatin C done. It's a little bit expensive procedure. Not all hospitals are set up to do. Is there anything else that you might do, a poor man's cystatin C, so to say?
So if
Dr.
I have
Govil,
to use
Dr.
diuretic,
Shweta, you can also chip in. So please.
can I just say, because
Yeah.
you showed us, if I have to use diuretics, I will only use IV diuretic in this case.
Okay.
A shot of IV, but not oral diuretics for sure.
So what would be your choice of IV diuretics? And
the IV diuretic, if I have to choose this patient, I will try furosemide.
And
but
what
then
would
again,
be, what
because
would be the goal of that?
The goal of that would be, if at all I have to, first things I said I will never use. But if I have to use, then before thoracentesis, I can try diuretic and see whether he diuresed. And if this is the normal renal functions for this patient, cystatin C is normal, I can try and see if he is having a diuretic response. So after admitting him, if I give him a dose of diuretic, which should be a small dose, and I see a diuretic response, then I may reassess him for giving a continuous infusion with albumin replacement. That I can try as a strategy.
Ramesh, can I chip in?
Yes, sir. Please, sir. By all means, sir.
Raki, he's not responding to diuretics when he was treated in Maharashtra.
Yeah. So we
Yes, sir. So
also decided not.
lacilactone oral diuretic absorption gets very poor, and the furosemide and this absorption, oral absorption is very much. It's almost 50% in an advanced cirrhotic who has
Yeah, but
gastric.
Dr. Raki, here the issue is of developing a complication due to diuretic rather than the effectiveness of the diuretic.
So, sir, that's what I said. I will never give.
Yeah.
If I
So
have
that's a
to
better
give,
answer.
this is how I
That's
will
a
give.
better answer.
Yeah.
Dr.
in this
Taneja,
patient-
Dr. Taneja, you can also chip in by all means. I think we don't know how many people have logged in, but anybody can. Dr. Shweta, Dr. Govil, do you have any different thought? Because we have to.
Can I say?
Yeah, please, quickly, please.
Sir, these patients are usually not tolerating diuretics, and even if we give diuretics, we can only give a slower dose. So, is there any role of pleural like catheter placement in these patients with refractory hydrothorax? Because these patients have repeated refilling hydrothorax. So, any role of tapping?
Right. So we will talk about that as the case.
Sir,
moves
in
on.
this, can I add something?
Yeah,
So
please.
in this patient basically already established is not responsive to diuretic and is presented, yes, with a creatinine of 1.1, as Raki said, is probably sarcopenic, and this creatinine is high for a patient with cirrhosis. But has he got reduced urine output? Why are we giving him a diuretic right away? We haven't auscultated his chest. We haven't seen whether he has any crepitations.
We did that. He has no breath sound on the right side, and he has no adventitious
Yeah, he
sound
has a
on the-
hydrothorax. He has a hydrothorax, so he doesn't have pulmonary edema.
He doesn't have pulmonary edema. That is
so
why
he-
the question of.
So we, like Raki said, we'll probably tap, and then if required, if the saturation will definitely pick up with that, and then we can consider if we need a non-invasive
Right. So what is
ventilation
your
mask.
threshold for tapping the thorax? How much would we want to do? Just quickly, one word answer, please.
We would. This patient definitely demands a tap because he doesn't have
No. How
ascites.
much? How much?
We would tap a liter. We
Sure.
wouldn't just let it flow.
Sure.
Stop after a liter.
Right. So
And
what
then
we
graded
decided
tapping.
was that he had done
Gradual.
his transplant, and we went on to do the transplant evaluation. So this is what his triphasic liver study was like. So we confirmed that there was no SOL in the liver, there was no thrombus in the photomesenteric circulation, and he had a conventional hepatic arterial anatomy, and the lung changes were pretty much the same. There was nothing to be added by way of presence of any lymphadenopathy or parenchymal changes. So this is what his CT looked like. You can see that he has a massive hydrothorax. The portal vein is fine. You can see that the liver is quite D-shaped and misshapen, and it's a standard hepatic arterial anatomy, which is obviously important from the surgeon's perspective because we chose to go down the path of transplant evaluation for this patient. So he was transplanted. They didn't have a living donor option. Like I said, this patient is class 1 obesity with the, I'm talking of corrected BMI, and he was asked to stay within the city. On his follow-ups, you can see that the sodium values are about 132 or so. The white cell count is okay. And the bilirubin has been fluctuating. In fact, it's slightly higher than what he came to us with. He came on the first week of a follow-up after discharge, and 1.6 liters of fluid was tapped from the pleural space. There was no evidence of SBE. This is what his X-ray looked like. You can see that the mediastinal shift is even more marked. He was tachypnic and his respiratory, and he was saturating 84% on room air. And this is what it looked like at the time that we tapped him. As always, the pleural fluid was sent for analysis, and we did not see any evidence of SPE. The MELD sodium at this stage is 27. Mind you, we started with something like 26. So revisit trial of diuretics? Probably no. In the interest of time, we'll quickly move on. Pigtail, somebody just spoke about that. So any takers for pigtail? Raju, Raki, would you want to do that at your center?
Pigtail placement, so I'm not very sure, but if the patient is requiring, I will do first in this particular patient, pigtail will be helpful because he's having a refractory hydrothorax based on the history. Okay. But not for all patients for the first go. That was the thing I wanted to make a point. In this particular patient, I will put a pigtail because he will require frequent thoracentesis. So I will tap it so that I can tap it whenever he gets into respiratory distress. And what we try to do is that we don't tap means large amounts of pleural fluid at a time. We tap little amounts so that the patient does not get the circulatory dysfunction and he feels comfortable. And obviously, right. Sorry, sir.
Any other thing you would want to do at this stage?
So an IV placement, I will definitely consider in this patient.
That is non-invasive ventilation.
Yes, sir.
Right. So this patient is homebound, and maybe not in ILBS, but at other places there are issues with finances. So one has to be extremely careful about what the patient is spending. So he's going to spend a lot of money on his transplant. So you want to save resources as far as possible. This patient is used to a saturation of about 84-85%. So we decided to keep his care domiciliary. He had good support at home. His daughter extremely well clued in. And by any other, I was trying to probe if anybody would want to start midodrine, because again, I see that to be done very commonly in patients who might not be on diuretics, but in whom we might want to reduce the interval between paracentesis, whether it is abdominal or thoracic. But maybe we can discuss this towards the end. So this patient was tapped, 1.6 liter was, Raki, would you give albumin to this patient while we are tapping?
Yes, sir, of course, we should give albumin.
Sure. So we did the same. So he came back in about a fortnight's time, and just to take your attention to the extreme left side of the slide, he came at 11:30 in the night with fever of 2 days, dysuria, and he said he was passing small amounts of urine and there was frequent micturition. He had temperature of 102, respiratory rate of 32, heart rate of 132, pressure was 90/55, saturations at room air was 80%, but the mentation was preserved. And you can see that even though he denied the use of diuretics while he was homebound, mind you, and I'm sure everybody's experience would be like this, many patients, when they realize that they're having to visit the hospital again and again, they might be surreptitiously taking diuretics, not realizing that it would harm them rather than do them much good. But this patient's daughter is a very reliable person, and she vouched for him not having access to the pill box. So we sent off the cultures from the ER. The urine culture came back as showing a growth of E. coli, which was sensitive to carbapenems. The pleural fluid was sampled again and it was sterile. And as you can see, there is a marked increase in his MELD score. which is not unusual, and the MELD score has climbed to 38. So this is what his X-ray looked like at the time that he presented to the ER. And like I said, he was always tachypneic, and this time even more so, and he was tapped again. And this is what happened. He was admitted to the step down unit. Can't hear. Okay.
Go ahead,
So,
Dharmesh, go ahead.
Sir, can you speak out that question, sir? I think somebody wanted to say something.
No, I also didn't hear. Go ahead. You start.
Yeah.
Keep on going.
So this patient on admitted on the night of 29th, and on 31st, the values of creatinine and urea are as shown. The sodium has dropped to 126. You can see that there is a blip in the white cell count. It was 7,000 change on outpatient basis, and it has jumped to about 2.5 times, 84% polys. So management strategy very quickly: IV antibiotics plus albumin, IV antibiotics, albumin, vasoconstrictor. Charles, would you want to take that?
Sure. In our center, we'll go for IV antibiotic, albumin, and vasoconstrictor because patient's creatinine of 6 just jumped from 0.9 to 6, and yes, she has got a UTI, so IV antibiotics, and we'll treat it as a hepatorenal syndrome.
Rakhi, your thoughts on that?
So I would need additional data
Like?
regarding his blood pH, other parameters of the
So his
aspirate.
lactate was 2.9 and the pH was 7.36.
His pH was compensated.
Yes. And lactate was 2.9. It's neither here nor there.
And he was oliguric, or he was still producing?
So he was passing small amounts of urine, frequent micturition, which is not unusual when people have urinary tract infection. So he didn't have a count.
I would catheterize this patient. This patient obviously need admission, so I will catheterize this patient. I will see the blood gas, and I will give a trial of IV albumin. And over here, I will try and use 5% albumin and see the response of this patient. The hemodynamic response based on the MAP, the tachycardia, lactate, or blood gas parameters, and urine output after catheterization. I will start off with IV broad spectrum antibiotics here because we don't have the cultures. But this patient
culture grew E. coli, which was carbapenem sensitive, and I mentioned that he has mentation preserved. So I would never catheterize a patient like this just to measure the urine output. All right, so we can always have timed urine outputs on our units. So the reason I put this question is because he has got a non-SBP infection, and there is a very strong lobby in Europe which says that for non-SBP infections you should not use albumin, and just antimicrobials are there. So that is why I wanted to pick your thoughts on that.
So, but creatinine is 6, sir.
Yeah, that's fine. So he has got urosepsis. Anyway, so there has to be some confusion. If there will be no confusion, there will be no fun. So Rakhi is now leaning away.
I am very much favor of catheterization. I've seen.
But I would never catheterize this patient. There are very few things I am dogmatic about, but I would never catheterize this patient.
But Rakhi, won't you induce the SBP by catheterization?
Yeah, so more interventions is always
early urine output, sir. We try to achieve.
I understand your purpose, but the complication
of target the float resuscitation based
mentation preserved. Observe for a period of 6 hours while you are doing whatever you are doing. Use a bedside ultrasound to see what is the bladder volume. It really does not matter whether he's peeing every hour or he has made that 600 in those 6 hours that you observe him. Let's move on. I'm very dogmatic about this.
Okay,
sir, so no catheterization. So what do you think is the AKI for the cause of this patient? Do you think it's urosepsis, surreptitious diuretic use, HRS physiology, or anything else?
It could be primarily the urosepsis in the background of little bit HRS physiology.
Ji, sir. So what are your thoughts on adding vasoconstrictor right from the word go, sir?
There are 3 points we have raised till now. IV antibiotic, there is a unanimity, there is no doubt about it. Carbapenem sensitivity is there, everybody will carbapenem. If somebody is not giving carbapenem, they are harming the patient. Coming to the albumin, so to give albumin, we need to do a thorough assessment of the patient, his fluid status. If we feel that patient is deficient in fluid, then we might go for 5% albumin. If we feel that patient is not fluid deficient, he is maybe overloaded or euvolemic, then probably 20% albumin will be a better choice rather than loading further volume.
Right, sir.
Looking at the vasoconstrictor, I would like to know his mean blood pressure. If his mean blood pressure is more than 70, then probably I will hold the vasoconstrictor.
Yeah, it was 90/55 in the ER, sir.
No, it was in ER, but we are talking about the ICU now when the
Right.
patient is admitted. So
Okay.
if his blood pressure is low, of course, there is no doubt about it. I'd like to increase the mean arterial pressure up to around maybe 70 plus.
Sure, sure. That's a fair thought. So,
Dharmesh, the bilirubin has shot up.
yes, sir. It was 10.8, sir. So his
Why is that?
Yeah, so we know that whenever patients have sepsis, there will always be an additional hit to the liver and the intrahepatic cholestasis worsens. So that is there even in non-liver patients. We oftentimes don't do their LFTs. So if next time we see a patient who's having pneumonia, you will see that his bilirubin will be more than what it used to be. If you have a patient on the medical side who's got a UTI or pyelonephritis, you will find his bilirubin is more than what his baseline would be. But we pay attention to this only in the context of liver patients, sir. So bilirubin goes up in most patients who get admitted to hospital with sepsis. So this is the intrahepatic cholestasis due to sepsis. So I think surreptitious diuretic use. Any other clinical feature or lab tool to aid differentiation, Rakhi?
So this patient has urosepsis. So there is a, it is basically lab tools. If you're talking about biomarkers, the question.
I don't know. You have to tell.
No, I will not use any. I don't need anything in any patient if the patient is responding well to our conventional treatment.
Right.
And especially in urosepsis, there is no need to do. The only biomarker which is helpful for us is NGAL, and
Right.
it is not reliable in urosepsis.
Right. Absolutely. So that is what I wanted to hear from you. So he has a blip in the white cell count and urosepsis, so which is what we think is the reason for his AKI. So what we did was to treat him with ertapenem, IV albumin 20%. His IVC size was 1.6. The SVC size was 1.4. Please remember both of them are fallacious because he's got moderate ascites and he's got a significant pleural effusion. His TAPC was 2.2. His fractional shortening was 32% and ejection fraction was 64%. So I think this
So,
patient.
sir, can I just say something?
Yes, sir. Please, sir.
In the patients where the intra-abdominal pressure is high or because of this large volume ascites, we can very well check either carotid flow velocity, carotid artery flow velocity, and the VTI variability.
Absolutely,
so these two
sir.
indicators
we can use those vector integrals.
Yeah.
So he was seen by the cardiologist who felt that he was euvolemic, he was adequately filled. So because this patient's mentation was preserved, we kept him on oral fluids and we gave him ertapenem, 20 grams of albumin, and we started him on vasoconstrictors between 29 and 31 because we saw no difference in the creatinine value. So on 31st, he was initiated on terlipressin. So that is what the unit did. So I'm not sure that it is the right thing to do or not, but that is what we did. So we chose to give terlipressin. So what are the checks needed? Shweta, can you quickly take that? We just have got 11 minutes. Can you tell what you would do when the doctor, who's probably quite naive, writes from the ER that, okay, give this patient 1 milligram Q 4th hourly of terlipressin with albumin. So what are the checks that you would run quickly before you start following those orders in the HTU or in the ICU?
I actually have missed the initial part of this because I think I got disconnected. Is there any comment on urine output? Because the creatinine is definitely high.
Yeah, so he was taken to the step down unit, and because his mentation was preserved and the unit cardiologist felt that he was adequately filled, he was given ertapenem, 20 grams of IV albumin, and he was allowed oral fluid intake. And he made about 500 ml urine in the next 6 hours.
Right. So I think we would, and he is the one with hydrothorax and ascites.
Yeah, he's the same patient. Yeah, we've not gone to another case. It's the same patient.
We've tapped him and we've also given him some amount of albumin, 20 grams, 100. Yeah. So I think that we should give him a chance with, not give him terlipressin right away.
Okay.
The urine output could pick up. Maybe one day we could wait. And then, because terlipressin in this setting, terlipressin has its own complications.
Now, what would you do? Supposing you find that, so you find that the doctor has written terlipressin and you will say, no, Dharmesh, you are an idiot. This fellow is not the right candidate for.
I'm asking for the blood pressure.
So his pressures in the ER were 90/55 and his hemodynamics were only a little better when he came to the unit. So as you can see, between 29th and 31st, his creatinine has only marginally changed from 6.2 to 6, and the urea has gone up to 195.
So if you would permit, I would want to start him on noradrenaline rather than 30%, because that would raise his blood pressure also a little bit, because he has a cirrhotic blood pressure 90/60.
Sure.
And
sure, that's a fair thought. So we'll come back to visit this thing again. And you already said that you would want to use noradrenaline rather than terlipressin. But anyways, the checks for terlipressin is that you must have an ECG, you must look for the rhythm, you must look for the QT interval, and most importantly, you must look at the extremities. So even if someone has got an HRS physiology, that is one thing that we would always do in a patient in whom we are about to start terlipressin. And every day, at least 2 times, the patients would be stripped to look for any cutaneous side effects of terlipressin. So this is the policy on our unit. So you can see.
And also watch for the loose motions.
But that is almost ubiquitous, and that is something you can do very little about. So this is because this is almost a ubiquitous side effect. So this is what happens on 4th. You find that the creatinine has come down to 1.1 and urea is 104. He has developed low HB. So Raki, I will come back and ask you this question again. So we started with 8.4 and his hemoglobin is 6.9. He's not been bleeding. He was transfused 2 units, 1 unit of PRBC on 2 consecutive days. His urine output improved. His chest catheter was opened intermittently. As you could see in the previous X-ray, we have pigtailed him because he was needing repeated thoracentesis. And then we took a decision on, what do you think we took a decision on? So he's already on the transplant wait list. All right, so we took a decision on, look at the MELD scores. So this is what happens on 6th. So there has been a significant improvement in his cholestasis. The white cell count started to look a little better, though still he's got high polys, and between 4.6 and 6.6, the values are a little inconsistent. But we find that the MELD sodium has gone down to 22, and the unit decided that we would subject him to TIPS. So you could blast us for that. But this is what we did for this patient. So this is a guy who's waitlisted for transplant. Now coming back again to when we pigtail. So we almost never pigtail patients who have a deceased donor option only. So pigtails carry a very high incidence of infections, and especially when you put them in the abdominal cavity, the surgeon always curses you. There was a pigtail that has been lying for a long time that is very likely to whet up an inflammatory reaction, and that would make the surgical dissection very difficult. So this patient's portoatrial gradient was 21 pre-tips and it was 11 post-tips. So Raki, what is your take? I know you are a very tips avid unit. So would you do a tips for a patient like this?
Not at all in this patient. I would not have done.
And we need to have you one time with Dr. Sareen. All right. So that is what we need to do. Why would you not want to tips him?
No, but
why would you not want to tips
for
him?
hepatic hydrothoracis, I'm not like in this patient who's just recovered from a sepsis event and he's due for his transplant.
So he's got 2 consecutive cultures negative,
and his bilirubin is high in the MELD score, sir.
MELD is 22.
Yeah, but I saw that the MELD is high not because of creatinine, which can be reversed. The MELD is high because of bilirubin and INR. And this patient has recently recovered from an infective episode.
Charles, would you consider this patient for tips in your wildest dreams?
No, we wouldn't, sir.
Okay, sure. So the reason for, so I would agree because you know, but then it also shows that different units have different policies which don't really come to the fore when we talk in meetings like this. So the threshold for doing a tips, safest MELD score of less than 15, 15 to 25, according to some 22 is the gray zone. Beyond 25, you should never do it. But what I have said right from the beginning is that this patient has got good muscle mass. This patient has never had any dip in his mentation. And this is a candidate for post for deceased donor liver transplant. And it's very important that we get the pigtail out. So we pigtail patients only when there is a next step available in this patient. So I'm not saying we did the right thing, but that is what we did. So is it definitive or interim? So you can see that post tips on 9/6, things look terribly good. But mind you, this is all true data. So this patient is still in the hospital. He got transplanted 11 days ago. But lo and behold, so this is what happens. So you can see there is a pigtail. 10/6, you can see that the hydrothorax has resolved. TIPS is an excellent modality to treat hepatic hydrothorax in the right patient, and you see what is going on now with his MELD. So it has gone up. So that was the reason for asking this question, whether it is an interim procedure or a definitive procedure. So please remember that even in Europe, they are talking about tipsing patients in child B cirrhotics and between MELDs of between 21 and 25. But it has to be done on a case-to-case basis. You should not opt for very high drops in the PAGs. Very modest drops in the PAGs are good. So what we do is to just leave the stent there. We don't balloon it. We don't do any plasty for the stent. And now coming to what I had wanted to ask right from the beginning, but I did not get from any of the panelists, look at the urinary electrolytes. So this is what we saw. So his urine electrolytes almost within a matter of no time, and that was his consistent pattern of urine electrolytes, and post tips you can see that there is a significant improvement. This slide has been given to me by Shweta, a very interesting slide. Maybe this program is being recorded. This is what we should do in any patient who's got NSRCA. And she's rightly mentioned that when these patients are managed in the ICU, you should do their ultrasound of the chest, look for B lines. She's also said that we should look for CKD. Every time you might not be able to get the evidence of CKD, echocardiography is very important to look for the volume status as well as the responsiveness to fluid. So this is what this patient was like. All right, so engorged neck veins, and he had edema at the time of the second presentation when we decided to TIPS him. And this is, he had edema right up to the proximal thighs. So this is the definition of HRS AKI, which again is slide shared by Shweta, just to say that we are still old school. We followed all the minor criteria for HRS. So on our unit, we follow all the minor criteria. So the protein loss and the microscopy, all of them, they still hold a lot of value for us. FENA is something that one would do. Less than 1% is tells you that it's pre-renal, but it has been shown that whether it is ATN or HRS or pre-renal in cirrhotics, you might get a huge overlap. And this is how the creatinine behaves over a period of time. In the interest of time, I would not want to talk about this. So this is what we should discuss in the next 4 or 5 minutes. So this is the confirmed trial recent publication, and Rakhi mentioned to me just before the program that we are treating all patients with terlipressin, and that is why we are saying now that terlipressin does not work very well. I would agree with her because all players are included in as AKI, but what this particular trial showed, and it was a very careful patient selection, and why I put it up here is not for the reversal of HRS or mortality or the number of patients who underwent liver transplant, but the signal for respiratory failure. So that was a very marked effect that was seen in this study, probably the largest study in the terlipressin space for patients with HRS1. And this was very early on. So as you can see in this left-sided curve, that the signal for pulmonary respiratory failure was very early in this cohort of patients. So the time does not permit. Would you want to patient who has got a non-resolving HRS to go on RRT? So our unit's policy is not to do so unless somebody is a candidate for transplant. We won't do that. Somebody goes on RRT, we would very quickly try to look for a donor for this patient, either on the deceased donor setting or on the living donor setting. You almost never want these patients to have extended sessions of RRT. A, they do not tolerate that well, and B, their chance of developing CKD rises very significantly if they continue to remain on RRT, and then at times you might have to go with 2 organs rather than 1. So this is the punchline of this talk. So whatever we have done, and this is for Dr. Rakhi and Dr. Govil and Dr. Shweta, and of course Charles. Charles is a clinician, so he's a foot soldier like me. Other people are all mounted soldiers. So what is the normal renal function in a patient with cirrhosis? It is not a normal creatinine. It's not also a normal biomarker. The biomarkers have been studied much earlier in other conditions than we started to look at them in the liver space. Rakhi discussed with me early in the evening saying that she studied about 18 biomarkers and found that they do extremely well. But there is ample cardiology literature and cardiothoracic literature, and Dr. Govil probably would be the right person to talk about it if time permits. And they have studied something close to 50 biomarkers. They are neither very good to define who's going to need an intervention and not very good to define who's benefiting from an intervention other than the serum creatinine value. So maybe we should talk of just hypercreatinemia, which is what we do on our unit. So 1.1 and 1.2 is very significant. You don't need to increase it by 0.3. So we talk of just worsening renal function or hypercreatinemia and not AKI1. Do biomarkers predict who's responding to intervention? Probably no. Is there a population of cirrhosis so even Raki, by your standards, if you say that all the patients would fit into your definition of HRS, would they all be treated similarly? The answer is no. So they would have a huge overlap in their clinical features, in their lab data. Even if you were to study biomarkers, there will be a huge overlap. And this is something that one must realize when you treat these patients. So that is why somebody needs to see them as a continuum, and then only you would know whether whatever policy of treatment that you decide for this patient is a good one. So why is it that terlipressin albumin cocktail, which was the flavor for all hepatologists and it was almost prescribed in a generic manner, is finding it so difficult now to survive? Probable answer is that we are seeing patients now who have metabolic syndromes. They don't have a good cardiac status. We are seeing more and more patients with comorbidities, iffy cardiac status, and that is why we are seeing. So it is almost like what you had, a diuretic refractory ascites. So this is probably refractory to terli albumin for various reasons, because we have always been renal centric, urine output centric, and not looking at the larger picture, which is obviously the lung and the heart. Because if those two organs are not good, there is no point getting your creatinine back to normal. So now the most contentious part: how many of us are takers for 1 gram per kg albumin? How many of us are takers for waiting for 48 hours? How many of us want that we should first only volume resuscitate and then add vasoconstrictors? For me, all of them are a no. And are diuretics useless in the management of renal dysfunction? This is probably the most contentious statement. For me, again, this is a no. So diuretics have a distinct role in management of acute kidney injury in patients with cirrhotics. I rest my case, and I would be very happy to take any questions which you might want to throw at me, including the chairpersons. So I think the fate of AKI in cirrhosis is going to go the same way as the first EGD study in the ICU setting. Govil sir, for you and Dr. Shweta. So this will go the same way as the EGD study, that very famous study.
Early co-directed therapy
Yes,
by
so
reverse.
reverse. So that reverse trial is what is going to be the fate of AKI, because we are only centered around studying what happens to the creatinine, not looking at the functioning of the other organs. So I think we don't do any of these things, and you can speak to any person working on our unit and they will tell you the same thing. So diuretics are a yes. We do not give this much amount of albumin. We do not regiment that first it is volume replacement and then vasoconstrictors. We do none of this. Thank you very much.
Thank you, sir, for very illustrious case, and it gave a ample learning opportunity. Thank you very much.
Raki, you wish to say something?
Sir, I still have this thing that I have a lot of faith on biomarkers, and maybe I can bring out 1 or 2 biomarkers which should be used in clinical practice.
So you should probably go to the Tribe AKI consortium. Okay, so this is the translational tools which are biological endpoints, biomarker endpoints. So this is a huge consortium. So they have for AKI, they have for HE, so on and so forth. So these biomarker and our foray into biomarkers is much later than the other specialties. So we started looking at them only after the Barcelona clinic study 2012. So before that, we were not talking about biomarkers, but in the cardiology space, they have been used since the early part of this century. And they have been found to be useless because they tell the injury, not the function.
Urine microscopy.
Oh, absolutely. So urine microscopy.
Pictures of urine microscopy should be given.
Absolutely.
On
So absolutely. So urine microscopy and urine electrolytes. These two are the key.
These two things are very important.
Poor man's. So what is my definition of somebody having a normal renal function? Not just a creatinine of 0.8. Yes, my definition of a normal renal function is creatinine of 0.8, not overloaded, sodium of 1.135 and above, and having urine electrolytes which are commensurate with his salt intake. So that is my definition of normal renal function. So it's not a biomarker based definition or a creatinine based definition. So I would, even someone has got a creatinine of 0.7 but a sodium of 125, according to me.
So in cirrhotics, urea is very important. We should be looking at urea levels.
So urea levels are important so the problem with urea is that when somebody has a chronic illness for a very long time, so urea becomes a bad thing, and when somebody becomes critically ill over a very short period of time, then again urea becomes a bad thing. So urea still has a role when you want to study the urine analysis in someone who's been taking diuretics. So there you know that FENA does not have much value. So there you have to use the fractional excretion of urea rather than this thing. So this patient also, if you saw, it was 180 and 6. So even if you convert that into BUN, you will have a value of more than 20. And you know that urea in a patient who also has a bleed. So there are a number of confounders, but I would not argue with you. Urea has its own value, something that we don't
We
talk
see
about.
disproportionately elevated urea as compared to creatinine, and these patients,
What are your thoughts on urine urea? So I would give more importance to urine urea than blood
urine urea is very important, sir. We
Yeah.
are not doing it. I've told him to do that. Fractional excretion of urea is very important test.
Yeah, we
And
do
blood
that all
urea
the time.
nitrogen to creatinine, what you said is a very important test again to differentiate pre-renal from
Right.
AD.
So I have to rush to the other hall. Esmi Mishra sir, your permission?
Yes, no questions. We are exceeding time. I think we should close down.
Right. And Taneja sir?
Sir, I think we can close this discussion, and I want to thank Dr. Dharmesh, all the chairpersons and the panelists for an elaborate discussion on the management of a critically ill cirrhotic patient. So we move on to the second panel discussion on drug-induced liver injury.
Thank you so much. Thank you.
And I invite the chairpersons for this session, Dr. Amna Shubham Bhatt, Dr. V.K. Dikshit, and Dr. Sandeep Thareja, to start the proceedings and invite the moderator and the panelists.
So thank you very much. I just want to confirm, am I audible?
Yeah, you're audible, ma'am.
Thank you. So thank you very much, Inasl, for your kind invitation and giving me this opportunity to speak on this forum. So ladies and gentlemen, for next 45 minutes, we will be discussing few interesting cases related to drug-induced liver injury. And I'm privileged to invite our panelists. And our panelist is Dr. Nipun Sharma, and he's an associate professor from PG IMR Chandigarh. Dr. Nipun, are you here with us?
Yeah, I'm here.
Hi, Dr. Nipun.
Good evening.
Great.
Yeah.
Good evening. So Dr. Manas Kumar, he's an associate professor from the Department of Gastroenterology, IMS, Odisha, and Dr. Abha Negral, and she's a consultant gastroenterologist from Apollo Hospital, and this is Jasloke Hospital, Mumbai. And now I'm privileged to invite our moderator of the session, Professor Harshad, and he is a professor from John's Medical Hospital, Bangalore, India. So Professor Harshad, over to you, please.
Dr. Amna, thank you very much. Welcome all of you. And I hope we can finish in 45 minutes. So we'll go like this. We have
We are getting echo.
There's a lot of echo effect.
Yeah. So what do I do?
I think all need to mute their mics.
So you go ahead.
The others can just mute their mics. I'll present the case.
I think it's audible.
Okay, now you are audible and there is no echo. Please go ahead.
Okay, I'll present the case in 1 or 2 minutes, and I'll have the moderators take over, give their take on the case, and then I will sum up with some additional points as well as takeaway slides. And the chairpersons are welcome to interject in between and ask questions. So this is the first case, and Nipun will be in charge of discussing this case. So this is a 57-year-old lady who presented with 10 days of easy fatigability, jaundice 10 days, itching for 10 days, and fever of 3 with chills of 3 days. And comorbidity, she had diabetes mellitus, on which was fairly under control, hypertension on metoprolol, hypothyroidism on thyroxine 25 micrograms. Okay. So this is what she presented to the hospital, and you find that on 29th of June this year, last year, her LFT was normal. On 18th of March this year, her bilirubin was 4.7, AST, ALT 147 and 397. And 10 days later, the bilirubin had shot to 14.8, direct of 10.9, AST and ALT about 12 to 15 times elevated, mild alkaline phosphatase elevation, and increased gamma GGT. Her ultrasound was unremarkable. Viral markers were all negative, and autoimmune markers were negative. Her medication history included history of ringworm infestation in 2020, 1 year ago, where she received 100 mg of itraconazole for a month. She had a recurrence of the infection 21, received a smaller dose for almost, I think, 38 days. She stopped this drug on her own after development of jaundice, and that is 13 days before she came to the hospital. And this is what was the fever pattern. She was admitted on this day. Her fever was swinging here, and then we did something that brought the fever down. Now, my question to Nipun, and before we take over for the next 4 or 5 minutes, your diagnosis, RUCAM, a little bit, how will you treat this patient, especially the fever, and thoughts about using medications which have a potential for hepatotoxicity for a trivial infection like a skin infection. Nipun, please.
So thank you, sir, for the introduction and this case. Basically, in this old lady, 57-year-old lady with a pre-morbid, comorbid conditions of diabetes, hypertension, hypothyroidism, with history of drug and recent onset injury in terms of raised OTPT with a R value of approximately 3.3 at presentation, and then going to, which is a mixed hepatocellular pattern, and then going to predominantly hepatocellular pattern. It is clear cut, it is looking like a DILI because of itraconazole. And we know itraconazole is a implicated drug here because recent onset within 90 days of the drug intake. And second thing was the RUCAM. Basically, RUCAM is the causality assessment tool, and out of different tools like Japanese criteria, CDS, and this one is the tool which is the RUCAM, Rus of UCLAF causality assessment tool, is recommended by recent APASL guidelines also in 2021. And again, according to this tool, there are 7 different criteria which can be used to see the causality. And first of all, which is the time to onset, which was 90 days in this patient, which was 2 points. Course of disease, whether it was progressive or improving, this was improving. So this was again corroborating with the drug induced. Then the risk factors, the patient was elderly female with the recent onset of drugs. And then the other drugs, if the patient was taking another drugs, that was not there associated with DILI, especially like metformin. And other etiologies we have clearly ruled out. Prior information on DILI about this drug was contributory. So again, this was point favoring the itraconazole induced injury, and re-challenge was not done because it was a severe liver injury. So the third question was, can you give it the question? The third question was basically, how will you treat? So I will stop the drug. That is the most important thing. Manage the symptomatic things which are there in the patient, like fever with paracetamol. And fever with chills, actually in patients with DILI, sometimes we do often see because of some immune mediated phenomena, but most importantly, we have to rule out the infections. And in an elderly female, one should rule out diabetic patient, one should rule out UTI especially. And after ruling out infections, yes, there is a case for low dose of steroids here because some amount of immune phenomena are seen with idiosyncratic DILIs. And although more role of steroids have been implicated in what do you say, that DRESS syndrome, the immune allergic phenomena. So basically, immune allergic type of injury versus metabolic idiosyncrasy, which is there in this case. So metabolic idiosyncratic patients with severe DILI without ALF, there is some data to suggest that yes, steroids can be helpful, but yes, with a careful watch on infections. The last point is about the medications for the cutaneous mycosis. I have discussed these findings with many of my colleagues, and because these sometimes what happens, this mycosis is resistant to basically the steroids. So the normally topical antifungals like terbinafine and topical antifungal agents. So they use itraconazole quite a lot over the last 6-10 months. They are using it quite often, and it is causing DILI in approximately 10% of patients, 1,000 patient data in our PGI. So, but ALF has not been seen so far in PGI. So yes, but if things can be managed with topical things, topical medications, yes, that should be used. If not, especially deep mycosis, subcutaneous deep mycosis, resistant bugs, the weighing the risk benefit ratio, the low probability of DILI because of itraconazole, maybe 2 to 5% reported in literature, one may give, and looking at the LFT patterns over the period of follow-up.
Yeah,
that would be my take.
And Nipun, thank you. And so this is what we did. We we gave paracetamol, and you can see the nurse's record here: paracetamol. It really didn't come down. So we gave this patient first initially IV hydrocortisone for 2 days, followed by oral prednisolone, and then you find after ruling out all sorts of infection, blood, urine, and all that, and you find that from 14 when she was there, and then dropped to 12, and within the span of about 4 to 6 weeks, you had a bilirubin that dropped to 1, and enzymes transamination as well as alkaline phosphatase normalized. Now the key takeaway is, and I think you already discussed the pros and cons of using drugs with hepatotoxic potential. I have another dermatologist who always never sort of uses these drugs because of the potential for hepatotoxicity. These are trivial infections. It can be very well treated with slightly prolonged course of local antifungals. But I think the opinion is divided. The jury is still out. So the key takeaway is, aside from cessation of the implicated drugs, steroids, and as Nupun discussed, it can be indicated because of the involvement of adaptive immunity. We don't have all the signs of immunity that can be seen in a patient, but immunity does play an important role, especially adaptive immunity. And there's an increasing role of steroids in this patient. So I would just stop for a brief moment and see if there are any questions.
So Dr. Sunil has asked how much amount of steroids and how long?
Yeah, so when you have this immunoallergic type of hepatitis, then there are people who just straight away start with IV hydrocortisone, 300 to 400 mg. But when you switch over to oral visolone, it comes to about anywhere from 40 to 60 milligram per day. And how fast you can decrease it or taper it all depends on how fast the patient's bilirubin improves. So over a period of about approximately, and we have a next case coming up, over a period of approximately 4 to 6, sometimes 8 weeks, you can take away steroids completely.
So actually there is lack of data, especially for steroids in metabolic idiosyncratic type of drug-induced liver injury. There are some data on immune-mediated checkpoint inhibitor-induced hepatitis and fluperitin-mediated DILI. But per se, in other DILIs, the data is very limited, and people use very heterogeneously all throughout the world.
That's correct, yeah. And I think most people now have gone away with the fact of metabolic idiosyncrasy, because that is that the group that believes in metabolic idiosyncrasy is sort of decreasing because they feel immunity or adaptive immunity plays a much greater role. Dr. Amna, I can see your hand raised. You have a question?
Yeah, 2 questions. Number one, because we do have PG, so must be attending the meeting. So how sensitive this RQ score is? And number 2, should we consider steroid in every case, or there will be some condition when we will be considering steroid?
No, I think the RUCAM, I think we have to mention, is I think there are many, 3-4 other scores, but the international consensus, the working group has finally come to the conclusion that it's RUCAM rather than the Dillon scores of Victoria, Victorina, and the other scores that are important. RUCAM has its limitations, I agree, everybody agrees, but overall it's so easy to use. It can be used in patients who do solo practice, unlike the Dillon, which requires hepatologists sitting together, making a conference call and using it. RUCAM, yeah, so RUCAM I think is a good score because, as you know, we all have to rely on exclusion criteria before we can incriminate a drug as being a cause of liver injury. Okay. And you're right, steroids, I think there's much debate coming up. I know that, for example, the Europeans are about to start a study on the utility of steroids in patients who have drug-induced liver injury. It should only be started or given when you have some clue of adaptive immunity or some kinds of hypersensitivity in this patient. When there are obvious hypersensitivity like skin rashes, lymphadenopathy, fever, facial puffiness, of course, you can straight away start it. But there are sometimes when you have lots of eosinophils without features, and when you do a biopsy, sometimes it's lots of eosinophils. In which case, I think we probably have to start steroids. But I agree, the opinion is divided.
Okay, Dr. Nipul.
Yeah.
This is Dr. Dichet. I just
Yes,
want to
yes,
ask actually, out of so many, like in meconazole, fluconazole, or ketoconazole, which you find is the most toxic? Because recently, during the mucormycosis, because of the COVID actually, we have plenty of patients, and there was a deficiency of the amphotericin B. So many of the patients agree they were put either on ketoconazole or etaconazole. So what you find, which is the more toxic among all these antifungal? What is your experience?
So experience says the voriconazole is the most, and along with that there is this itraconazole. Both are likelihood score B according to the liver tox basically. And then there are other medications of especially micafungin. Micafungin has got black box warning also with severe DD related to liver injury. So these are the special drugs. Amphotericin B hardly we see, very rare, and these are and then the ketoconazole azole group of agents, especially this thing, voriconazole, itraconazole, and posaconazole. And you need posaconazole monitoring, especially in patients with liver disease.
Okay, thank you. Thank you.
Yeah, I think. Any questions? No.
Biopsy. Okay. There was one question. When do you do biopsy in patients with
Yeah, I think we'll take that up because almost reaching time there, 32, we finished 9 minutes, but I think somewhere when we have the 3 other cases, we'll do that. We'll take that. So let me get to the next case, and case number 2, and Manas will discuss this, and I'll briefly present this history, and that is this 16-year-old girl presented with lamotrigine and valproate for a seizure disorder. So symptoms of jaundice, nausea, and vomiting started 23 days after the intake of these top 2 drugs. She developed skin rashes and facial swelling. But this facial puffiness as well as rashes subsided by the time she came to our hospital. She presented to a local hospital 20 days after symptoms, and LFT, as you will see, a markedly elevated bilirubin and enzymes. And this is it when she was presented to a local hospital, not to a hospital. And this is, you find the leukocyte count of 14,000 leukocytosis, but predominantly eosinophils are 15%. And then when later on eosinophils was 10%. But bilirubin 7.3 increased to 16.3, direct of 6 and 7 respectively. AST initially, and this is what happens, when you see the patient at first point of contact, you find that the AST and ALT is elevated. And maybe if you see the patient a few days later, perhaps 3, 4, or sometimes 7 days later, you find a marked drop in AST and ALT, but increase in bilirubin. So you actually have missed the peak when you have seen the patient who comes to you a few days later. And as you will see that when the AST and ALT goes down, the bilirubin, the alkaline phosphatase increases, and you find it's 257, but the INR was 2.5, elevated. Now, so we did, all the viral markers were carried out with a negative. Autoimmune markers also were carried out, they were negative. Ultrasonography was unremarkable hepatobiliary system. Liver biopsy showed these findings, cholestatic hepatitis, and I will just read this out to you. There is edema of the portal tract with presence of occasional eosinophils, arrow, with focal ductular proliferation. And then there's also perivenular, intracellular, and canalicular cholestasis because she came to our hospital almost a month after she had developed jaundice. And this is again what you see, that the bilirubin goes up a few days later, the AST-ALT has come down, and you find some cholestasis. Now, the question is, what's your diagnosis, Manas, and how will you address these questions in your discussion?
So, good evening, sir, and good evening all. Classical, this is something like classical, the combination is lamotrigine and valproic acid. So here the person who has taken this combination, usually having this cutaneous manifestation and liver manifestation, usually first diagnosis used to come to our mind is DRIS, that is drug-related eosinophilia and systemic symptoms. And where there is a certain gap or latent period is there, that is 2 to 8 weeks usually latent period, and people used to come at times after 3 weeks, after 4 weeks also, and they first presents with if you biochemically see, clinically they used to present with some cutaneous rashes, leading to Steven-Johnson of TEN-like features, then pharyngitis, malaise, nausea, these features, then gradually the liver biochemical derangement or that AST, ALT raised, and all those things happen. And if you look into hematological, there will be a neutrophilic leukocytosis first, then later on phase there will be eosinophilia, and this atypical lymphocytes used to come. And invariably in DRACE syndrome, liver is involved in 60 to 80% of cases. So this is a classical example of DRACE syndrome. Of course, in few patients of DRACE, there will be no cutaneous manifestation. However, liver is invariably involved in all those cases. And classically, these drugs like valproic acid and glucocorticoid, when you are using it, any new agent, they used to cause this 4 to 10 times risks of DRACE syndrome. They used to happen at times. So we have to be careful, and this DRACE patient, you have to conservatively treat them. At times, steroid is required. Liver biopsy, of course, required when there is, we want to rule out other, exclude all other disease, because DRACE is always a clinical, and exclusion of all other disease should be there. And we can at times treat them with steroid.
Yeah, any questions? I don't see the chat box, but if you can identify some questions and you can address. Yeah, Dr. Sandeep. Dr. Sandeep, go ahead.
All right. So,
Can you hear me, Harsha?
Yeah, Dr. Sandeep, go ahead.
Yeah,
Dr.
Yeah, one small doubt. He just mentioned that dress, no skin involvement. I mean, you cannot have a dress without a rash. In fact, 90% will have some sort of a rash. Liver involved is the commonest organ involvement, I agree. But skin involvement has to be there in dress.
Yeah, you're right. I mean, skin, that is, skin involvement is, of course, the commonest.
Stands for syndrome. I mean,
what
rash is
happens
always there.
Yeah, sorry. What happens is many times the skin, by the time you see a patient, the skin involvement has abated, and you only have these consequences of DRACE, and that is, clearly a liver involvement. And patients are not really very intelligent enough sometimes to describe the skin involvement. So you're right. Skin involvement is the commonest, followed by the liver involvement, and that is why I know I had just this discussion with Dr. J. Hoofnagel from the Dillon group. We for hepatologists, we use the term immunoallergic. Okay, we don't.
Absolutely.
That's because the world community has still not come to grips with the fact that liver involvement is so predominant in patients with DRACE. And what do we really call them? Because the dermatologists disagree with the term immunoallergic hepatitis. They say this is all drug hypersensitivity reaction. Whereas many of us who see these patients with immunoallergy hepatitis sometimes don't see patients with skin involvement. Or if you have seen these patients, the skin involvement is either minor or trivial, or the patient has completely forgotten about it. So you're right. What you just mentioned.
Dr. Manash?
Yes.
Okay.
Yes, sir.
But usually valproate also causes the microcytosis. But in this liver biopsy, we hardly find actually microcytosis.
Again, pardon, sir. Please again.
Sodium valproate, this also causes the microcytosis, right? As one of the manifestation. So what is your thought about this?
Sodium valproate, as such, that is drug-induced liver injury, sodium valproate. But here the mechanism, that is immunoallergic hepatitis is the mechanism here. Okay. So when single agent as a sodium valproate, we are using single agent, and later on as a drug-induced liver injury, microsteatosis used to happen in valproic acid. Here the combination, that is valproic acid and lamotrigine, that have done the trick here. That has done this immunoallergic hepatitis and this DRACE syndrome. Classically in liver biopsy, we used to find this eosinophilia and this edema that used to happen in this DRACE syndrome.
Okay.
Dr. Dikshit, I think you raised a very important point, and that is why I had listed this third point, drug-drug interaction. Both lamotrigine and valproate should not be combined. In fact, they have a box, a black box warning. when you combine this, what happens is the valproate increases the hepatotoxicity of lamotrigine. And so because it increases hepatotoxicity, you find, you're right, valproate does not produce, generally it does not produce hypersensitivity phenomena. It produces fatty acid disease. But then when you combine it, the blood levels of valproate goes up, and that produces immunoallergic hepatitis. And that is why that combination, and that this, if you ask me which among these two drugs produce the injury, that's probably it's lamotrigine, because lamotrigine classically is known to produce drug hypersensitive phenomena, including DRESS syndrome. That is why I just put this. We have to be very careful about this drug-drug interaction. Many of the physicians take it very casually, but these drugs should not be combined together. Either you give one alone, or you do not give it and give the second generation anti-epileptic drugs like levetiracetam, because it has very hardly any potential for hepatotoxicity. So this is what happened. All patients with DRESS syndrome, perhaps we have to treat them with steroids, either IV or oral, depending on the severity. And once you have treated, you find that the bilirubin has now dropped to 16, 14, 2.8. But then it took such a long time, almost close to 8-9 months for the bilirubin to drop. That's what happens sometimes. You don't expect results faster. This patient was on steroids for a long period of time. And one is patient, then over a period of months, you'll find the disease has resolved. But we also had to give this patient azathioprine, because she developed steroid-dependent adverse effects, including moaning of the face. But after we gave this, and you can see the left improved and normalized after 2 years of illness. And she had come here about a year ago. She's doing well. Liver tests are normal. So prolonged cholestasis, which resolved after 2 years of initial presentation of the disease. So if there are any questions, we'll take them.
Dr. Harshad, Dr. V. Janti wants to know what was the indication of liver biopsy in this patient?
Yeah, so this liver biopsy is because the general phenomena is once you stop the drug and you give the steroids, that most patients sort of improve. So when patients do not improve, you find that the bilirubin is static or sort of going up sometimes, and that is why we had to start an azathioprine. But that is the time when you have to do a liver biopsy, because liver biopsy, as you'll see, it will not only tell us the extent and the severity of injury, sometimes it also helps us in ruling out diseases. So in this case, that was why it was done. And you'll find the key takeaway from this slide is that delay with hypersensitivity, it's very common. We see in about 20-25%, even in the Indian network of drug-induced liver injury consisting of 1,288 patients. We saw DRESS phenomena in close to about 20% of patients, 19%, which is quite high. And many of these patients go to a general medicine doctor. They continue to give the drug. And one of the cardinal sins you can do in patients who are taking these drugs and have injury is that continue the drug. Unfortunately, you need to stop the drug when you first see it. And I find this internal medicine physician sometimes mistaking a skin rash for chickenpox, or measles. So they think of all diseases except, for example, drug. And this is what Osler always said. Look, listen to the patient. He's telling you the diagnosis. So I think the diagnosis is just in front of you. And as we discussed, the liver is the most common organ, and sometimes it can lead to acute liver failure. And steroids are the treatment of choice for these patients. Please start steroids, especially when you have fever and hepatitis that is increasing. So let's get to the third case. We're just right in time to the third case. And this is a fascinating case, and Abha will join us and give her insights. And this is a 55-year-old lady who had joined for several years. She presented to the hospital for jaundice of 1 month duration, and on probing clearly said that she was taking this Ayurvedic medicine for 2 months. Now this was the LFT when she visited her hospital. Bilirubin 44, astonishing, 44. Direct is 24. And despite all this, she was relatively calm, peaceful, except that she had little itching and had clearly jaundice. The AST was 724, ALT 1,263, alkaline phosphatase 78, INR 1.35. And again, as we know, we did all kinds of hepatitis markers, viral hepatitis, autoimmune hepatitis were all negative. And ultrasound showed only hepatomegaly. And this is what she had. She took these two little cakes, as you can see, and this was broken down for analysis, and that's why you see these samples being displayed. Now, When you ask her, she has no clue what she was taking, except that she was given these cakes. She had no prescription, so we don't know what she was taking. And then we had to make a diagnosis. So Abha, if you can just come over and take over and just tell us what your thoughts are.
Yeah, thanks Harshad and thanks Inasl. So this seems to be a typical case of herb-induced liver injury, now also being often referred to as HILI, H-I-L-I. Now we know that in the Indian Delhi network, which Harshad spearheaded, that about 14% of all the delays were due to herbs, and we use the terms complementary, alternative. Complementary is when you use a herb in addition to the specific allopathic medications. Alternative medications are those when they are used exclusively. And then you have traditional medicines which are ingenious to those areas. So all these have been used. And the challenges really is because most of them are polyherbal. So you don't have one specific herb. Like, for example, we have Live 52 herbs in it. So that's a challenge. How do you establish a diagnosis as to which one of them is hepatotoxic? There are a lot of drug interactions. They are often taken with allopathic drugs. So what is the interaction happening which is causing a problem? We don't know. There are no well-established dosing guidelines which are available like they are for modern drugs. So how do you know which is a toxic dose and which is not? Often these are idiosyncratic reactions. So dose may not even be important. You may have just a small amount of drug and the patient may develop a problem. Now, how do you identify the herb? That is a problem. You may do it by botanical means if you actually have a patient getting you the plant, or you may have to do phytochemical analysis by HPLC or DNA analysis, which is not easy to do. Drug levels of the herb. We don't know what are the toxic components in these herbs. So how do you measure drug levels? And most important is often these herbs are cause of ACLF. About 30% in the Asian population had acute and chronic liver failure due to these herbs. So that becomes even more challenging to diagnose. So I think these are challenges, and the way we've learned, we've recently published our data on Giloy or Tinospora cordifolia related drug injury. And the one thing we've realized is we have to go beyond and ask the patient about use of herbs. They will not volunteer this information on their own, and you have to really be a good detective to do that. Pharmacovigilance. Now, basically, what do you mean by pharmacovigilance? It means detecting, assessing, and preventing side effects of a drug. And how do you do that? Just as we have in modern medicine, we need to have proper phased trials, clinical trials for these drugs as well. We also need to have post-marketing surveillance. And there are some very good registries in the West. For example, in the US, you have the livertox.nih.gov. So basically, it's a registry which gives all the drugs which are known to cause DILI and the details about each of these drugs. So I think we should have similar drug registries for all drugs in India, allopathic, homeopathic, Ayurvedic, all of them to give us a, for example, green tea extracts. Now we know that this is known to cause DILI, and you have now the US pharmacopoeia insisting that it is mentioned that these patients who take green tea extracts can have liver injury. So I think some labels which can be put on these drugs which are well established to cause liver injury, which will help in pharmacovigilance. Now, the most important thing is how to minimize polarization and disagreements. I think, so as we realized in our recent publication, there was a lot of reaction to this. So, the two communities got kind of divided. The Ayurveda community came up saying that, they became emotional about us mentioning the side effects. And what we really wanted to emphasize is that we are not against Ayurveda. We're not even against the drug. What we want to just highlight is caution that this drug can cause liver toxicity, just as allopathic drugs can cause liver toxicity. So I think the best way to minimize polarization is to come together, say that our bottom lines is good science and not emotion, and then talk it through, and then do what the Chinese did. The Chinese actually have a journal of integrated medicine where they had the allopaths and because we know that traditional Chinese medicine is well described to cause DILI. So they came together and they laid down a structured kind of algorithm of how to prove that a particular drug or improve the level of evidence for a drug-induced liver injury. And they said one is you have to identify the herb or at least exclude toxins and other contaminants which could also be contributing to DILI. So I think one has to come together without any emotions, use pure science for the betterment of patient safety. That's what I would say.
Any questions? Because I really find all over the world you find herbal drug-induced injury increasing, and I wonder how do you have these things in Pakistan, Amna?
So we don't, yes, the drug-induced liver injury is pretty common. And again, the use of herbal medication or a traditional medication is also common over here. And we do see cases coming with drug-induced liver injury, including ELF and ACLF. However, there is no registry related to identify these drugs and all, but this is, I think it's a common problem in the region, not only in India, but Pakistan, and I'm sure that other South Asian countries as well.
In fact, Harshad, I just read a report coming from South Carolina in the US, where they mentioned that Ayurvedic drugs are also being very commonly now used amongst the American population. And of course, there are many Indians and South Asians there, but it's not just that, amongst the Hispanics also, and they have reported Ayurvedic drugs. In fact, the commonest Ayurvedic drug which they mentioned being used in the US is ashwagandha, which has the highest incidence of DILI being reported. I mean, and for me, it was an eye opener when I looked at all the Indian herbs which have been associated with very common ones: turmeric, senna. I mean, you name it. Brahmi, these are being used right, left, and center, and it is now estimated with the pandemic, people, almost 70% of the Indian population is using some form of herbal drug to prevent COVID. So I think the reason we also realized the toxicity of this drug was because there was mass use of these drugs. And there have been many letters which have come to the journals mentioning that they have had similar experience with the drug because it was being mass used during this pandemic. Isolated use probably would have not got detected so easily, but because of this mass usage of these drugs, I think it has become more obvious.
Yeah, I liked Alba. You mentioned about the Chinese. They know that there is a problem. They have their own journal. I think we just have to be open, and it's not incriminating a drug or particular specialty. It's all many of the times it's idiosyncratic. So, there is, the drug may be good, but the person may not react to it properly. So that's also the clue. And then multiple ingredients. I mean, there are 50, 160, 70. And so that all leads to drug-drug interaction, as we discussed in the last case. So Casey, taking this, so again, we had this, what we did is we sent this for analysis, and you'll find this of the 4 powders, it contained these 2 which were highlighted. Triphala and Azadirachta indica, and that is the neem. Neem is very commonly used in India, and the second powder also contained this. And again, these Triphala contains 3 compounds, and this drug, the neem one, you find it being used very commonly in various societies, especially in India. And we really don't know what this drug-drug interaction is. I highlighted these 2 because these 2 clearly have been shown to be associated. I'm not saying it's the cause, but associated with many of the formulations that have gone on to produce drug-induced liver injury due to herbal supplements. So these are the 2 drug ingredients that we identified. And the key takeaway, yes, is that all of us, we really need to do a thorough and elaborate workup of cases. Every time there is a report of complementary medicine associated drug-induced liver injury by anybody, you'll find many letters to the editor being addressed by the complementary medicine community. So we need to be really careful and elaborate and do a thorough checkup. There is drug-drug herb interaction plus herb-drug interaction. And we didn't discuss this, but yeah, we all know that liver injury can be mild in a lot of patients, but it can be severe, including leading to acute liver failure and ACLF, where ACLF, especially from drugs, constitutes to almost 75% of patients. So we are right in time now, and we'll get to the 4th case, and that is, this is a 4th, and you'll find Krishna Das presenting or discussing this case. This is a 35-year-old lady she was postpartum 3 months when she came to the hospital, and she presented with fatigue, anorexia, nausea, and yellowness of the eyes of 2 months duration. She had no drug allergies on this, and there was a past history that she had probably suffered from jaundice, which abated a little bit, although the details were not clear whilst she was pregnant. But now she's 3 months post-pregnancy. No drug allergies, and when asked, she said she was only taking lisinopril for the last 3 months. There was no family history of liver injury. Again, ultrasound unremarkable, all viral markers negative. Autoimmune markers, you had ANA that was strongly positive, 1:3,000 and 3,200, and direct Coombs was positive. And this is what was the LFT. This is a case that we saw in 2014. He initially had a bilirubin of 17, which increased to 29 and 26. AST, ALT, 380, 324, and approximately 8 to 10 times elevation. Alkaline phosphatase, mild elevation, normal GGT. And you find that eosinophil was 0%, although the monocytes was 8%. And this, because she had she actually was sent for a liver transplantation. And this is the liver biopsy. Dr. Krishnadas, if you can just take over, please.
Yeah. Thank you, Dr. Harshad, and thank the audience for having given me this opportunity. So we have here a young lady with acute liver injury. Her viral markers has come as negative, and she has got a very high ANA, and her direct Coombs is positive, again indicating some amount of autoimmune disease in her. There is no evidence of sepsis, and we have the liver biopsy, the low power view, probably showing some amount of submassive necrosis. Can you go to the next slide, please? Yeah. And the high power view, you find that there is a lot of monocyte infiltration. I mean, mononuclear cell infiltration, lymphoplasmacytic infiltration. I cannot definitely see a portal tract, but I feel that there must be some amount of portal tract widening as well as some amount of interface hepatitis, and some inflammation coming from the lobular region also. And you can find certain areas where there is rosette formation. So taking all this into consideration, most probably this patient is having autoimmune hepatitis, even though we don't have the IgG levels and the globulin is not very high. And having said that, whether this is a case of classical autoimmune hepatitis, because this lady is only taking lisinopril and she is quite young, so we need to go back to the pregnancy period and take a proper history, to take a deep history regarding any other drug that she was given during the pregnancy period, because it is unlikely that she has suddenly developed hypertension. It could be a continuation of a pregnancy-related hypertension.
Yeah, the Krishnadas raised an important point. When the patient has come to the hospital, she's taking a drug, of course, but they never mentioned to you what they were taking earlier. That history that she had some jaundice during pregnancy, so was not very well dealt with by the referring physician. So here it was that the hypertension she had during the second trimester continued it, and then she was started on alpha-methyl dopa, 250 mg. And I know alpha-methyl dopa is one of the safest drugs known to mankind, especially in pregnancy. So you give it all the time. You can't use the other drugs, but you can use alpha-methyl dopa. Obstetricians just love it. 250 mg BID. And there was some, the 6 months she developed jaundice and dark urine, but according to her, sort of it improved. And most patients just get used to it, and then they don't really understand what's happening, especially with the pregnancy changes. And you find that
the duration of jaundice at that time.
Yeah, so she said she developed jaundice for about 2 or 3 weeks, and then she said we don't have the LFT, and she said it sort of improved, and that's why I said we don't have that detail. But it less likely or unlikely, and the body always undergoes some kind of adaptation. So I really don't know whether there's some adaptation. She continued with it was a precious pregnancy, so she was really keen to have this baby. So she continued it, and then what happened is that after she delivered, and this was a preterm delivery, the doctor actually increased it to 1000 mg BID, and that's when the jaundice came up again, and they couldn't find a cause, and they continued for the 3-4 months. The patient herself stopped it on its own, and then the general physician put her on lisinopril. So once she came to this hospital, then of course we started on azathioprine. We started on Visolone, and as you will see that the LFT's liver function test gradually improved, and finally, in about I think 4 or 5 months' time, it sort of normalized. So there was the follow-up recurrent. There was no recurrent hepatitis in the last 4 years that we have seen. So, so final diagnosis is alpha-methyl-dopa autoimmune hepatitis, and Krishnadas will take us through with the associations.
So we are a case of autoimmune-like presentation due to a drug. So what are the possible drugs that have got a definite association with DILI or autoimmune-like hepatitis? Dihydrolysine, halathane, methyl-dopa, minocycline, nitrofurantoin, oxyphenecytin, and thionylic acid. Most of these have been withdrawn, but we still have methyl-dopa, which is quite frequently used by our gynecologists. Nitrofurantoin is used in for urologic problems. Minocycline, many young ladies do take minocycline. So even the age, there's even an age difference. The minocycline usually produces disease in young ladies, whereas nitrofurantoin usually produces disease in elderly ladies. And there are probable associations with atorvastatin, which is one of the most ubiquitously used drug world over. Even though the rate of is quite low. Diclofenac, another commonly used drug, infliximab, which we are using more and more. INH, which in India the usage is rampant, and propylthiouracil. And there are certain drugs that have got possible association, like rosuvastatin, then adalimumab is another drug which has got possible drugs. Several emerging drugs have been in DI. Drug-induced autoimmune hepatitis. One is statins, that we already mentioned, as Dr. Abha mentioned. Herbal drugs, which is a very common, which is not very common, but among, if you consider the number of people who are using herbal drugs, the incidence of DILI is quite high in those, especially those people who take germander or those who take mahong, which contains ephedra. These can produce DILI with autoimmune-like presentations, and even supplements like hydroxy. Certain supplements can also produce autoimmune-like disease. So agents are physical agents like infliximab, adalimumab, etanercept has got is supposed to have the maximum amount of 1 in 120 patients can have DILI. Adalimumab is about 1 in 270, whereas for etanercept it is about 1 in 420. And immune checkpoint inhibitors, which is one group of drugs which is finding new and new usage as time goes on. There are 7 immune checkpoint inhibitors that are FDA approved. And the funny thing about immune checkpoint inhibitor induced AH-like presentation is that often the markers for autoimmune markers may be negative. You may get low titers of ANA in about 40 to 50%, but in the remaining patients, you don't get any markers at all. The other markers are usually negative in patients who take ICI and develop autoimmune disease. Can we go back?
I think we'll have to go because we are reaching time, so we'll have to. You have to discuss this.
I can just add one. I can just add that Giloy or Tinospora cordifolia also had this mechanism, autoimmune-like hepatitis. Okay. Exactly.
Okay, that is great.
Yeah.
Okay. So again, if you look at ICI inhibitors, ICI agents, they do not have the histological characteristics of the classical autoimmune hepatitis. So it's maybe you may have to have some amount of clinical this thing to diagnose the condition. So how can you differentiate between drug-induced autoimmune-like hepatitis and classic autoimmune hepatitis? Sometimes it is very difficult. There could be female more for drug-induced than for classic. So autoantibodies are present in both, but more for drug-induced autoimmune-like hepatitis. Cirrhosis. Initially, we thought that presence of cirrhosis ruled out. Cirrhosis was not present when you have a patient with drug-induced autoimmune-like hepatitis, but recent studies have shown that patients with CLD also can develop the same thing. So 27 and 33% in different studies, but still it is less than in patients with classic autoimmune hepatitis. Well, one thing is that if you don't have cirrhosis initially, they don't progress to cirrhosis if you have a patient with drug-induced autoimmune like this. So even though rare cases with nitrofurantoin have been reported, and relapse after drug withdrawal is practically never seen in patients who have drug-induced autoimmune like hepatitis. Whereas 60 to 87% of classic AIH will have a relapse after drug withdrawal. Over to you, Ashwin.
Yeah, so thank you very much, Krishnadas. And so the key takeaways are that drug-induced autoimmune like hepatitis is a differential in all cases of autoimmune hepatitis. There is clearly a subset of autoimmune hepatitis which is triggered by a drug. So we need to keep these drugs in mind. Drug-induced autoimmune, and Baba just mentioned, I think it's increasing. Every time you see both from Chinese studies and other studies, herbal and dietary supplements are somehow trigger the immune system. And you see increasing cases of drug-induced autoimmune like hepatitis. So, the catch is, it's like a Sherlock. You need to take a very detailed drug history of current as well as recent past. Patients generally don't give a history of drugs that they've taken 1 or 2 months ago earlier, but they all could stimulate the immune system. And generally no recurrence, as Krishnadas mentioned, no recurrence of autoimmune hepatitis once the offending drug has been stopped in these patients, unless of course patients have ACLF, where the ACLF prognosis is worse when you have underlying cirrhosis. But if you have no cirrhosis, then the prognosis is very good. So that's it. We have just overshot by about a couple of minutes, but I'm so happy we just finished in time. Thank you very much, all of you, for participating. And there's one question that was asked, which I said I'll take over in the end, and that is about liver biopsy. And liver biopsy, yes, when you have diagnostic confusion, you should use liver biopsy. When you want to do a prognosis, when you need from prognosis, we need to have do a liver biopsy, sometimes the transjugular route. And in presence of eosinophils, granulomas, there are two important things that confer a good prognosis in this patient. Presence of necrosis clearly confers a worse prognosis. And again, when there is diagnostic confusion, you need to do a liver biopsy. So otherwise, biopsy generally is sort of not indicated. So on that note, all of you, thank you very much. And yeah, go ahead.
I must thank actually, I must thank the moderator, Dr. Harshad, for nicely conducting and showing all the 4 cases and their importance. I am also thankful to all the panelists, Nupam and other people, Dr. Abha, Dr. Krishnadas, for a nice presentation and nice introduction. And also I would like to thank my colleague actually as the chairperson, Dr. Amna and Dr. Sandeep Thareja. Thank you very much. I think everybody must have enjoyed this session. It was quite informative and quite detailed. Thank you very much to all. Thank you to all.
Thank you. Good night.
Thank you all, and I invite you all for tomorrow's wonderful sessions again. And we have young investigator sessions and some state-of-art lectures, pediatric hepatology course, as well as very good discussions, and in fact a basic science workshop also tomorrow. And looking forward to active participation of all the delegates. I also want to thank the technical team for their fabulous support and flawless technical support. Thanks all, and looking forward to see you all tomorrow.
Thank you.
Thank you. Thank you. Thank you, sir.